Welcome, EGP Learners. This episode, where myself and Andy are going to cover everything that's been happening over the past couple of weeks or so, including some significant updates in terms of neighborhoods, the big buzzword for 2025, as well as AI Scribe, the other big word in 2025, as we continue to tech enhance your primary care and learning. So let's get cracking, shall we? Hey, GP Learners, and welcome to this episode. Myself and Andy are going to be covering all the latest news in general practice as it's been happening. And there is so much to cover in this episode, including two key themes, neighborhoods and AI. But how are we doing there, Andy?
Yeah, I'm doing pretty good, actually. It's been a hectic few weeks for us, hasn't it, Gandhi? We've had the PCN Plus conference last week and then the GP5T9 conference for GP trainers at the weekend, both of which EGP Learning plays a key role in organising. So it feels really hectic, and I'm looking forward to taking some time to reflect on those two themes that we'd identified within the PCN Plus conference. So really looking forward to this evening. How are you doing?
Yeah, keeping busy. So I've had a bit of a hectic week, as probably people have realized from my social media. So not only have we had the PCN Plus and GP5T conference last week, this week I also attended the Accurx conference in terms of their Connect one for users, and then also went to ASMA and talked to some accountants as well yesterday. And within that, still working in practice and doing all the stuff that GPs need to be doing. And there's lots of stuff that GPs need to be doing, especially as we're going to cover in the neighborhood guidance as we're coming to it as well.
Yeah. What were you talking to the accountants about, Gandhi? Was that a personal practice matter, or was that about technology?
No, it was about technology and how it impacts potentially the accountant's perspective. So it was a slightly different talk to what I'm used to giving, and I'm hoping it went down well. The feedback I got was that it was very well received, so I'm hoping that was the case. But yeah, it was definitely a different kind of talk to give.
Okay, sounds really interesting. So you're branching out into other industries, Gandhi, providing advice into other industry sectors.
I was asked if I wanted to speak, and I was like, "Yeah, let's go for it."
Yeah, no, fantastic. There's lots of transferable knowledge. Yeah, so so shall we get started? It might be nice just to reflect on the conference that happened last week, because people still have the opportunity to sign up and view the talks, because all of the talks were recorded. We had an audience that were present at the venue, Crown Plaza in Nottingham. We like to bring this to our home city. Third year of this conference, isn't it, Gandhi?
It is, yeah.
And I think what I really like is that we've developed a really, it's still fairly small and niche, isn't it? About 100 people in the room and sort of 60, 80 people online, but a really high level of expertise in the delegates. Lots of primary care network managers, digital transformation managers, clinical directors, ICB place type people in the room, and really good quality speakers as well, and like a really good audio visual experience, meaning that all of the talks are recorded with great video and audio, and people can still sign up and watch them back now. I guess people, how do they do that, Gandhi?
So if they want to, it's the PCN Plus web link that you can see it now, bit.ly/PCN Plus 2025. Slightly weird with the capitalization and stuff, but don't worry, I will put that in the chat links and stuff for people to use if they want to and things. But I guess the cool thing about this conference, like you said, is that it's recorded. And actually what we're going to do now is show you one of the recordings, I believe. Is that correct, Andy? Or have I
Do you want to go neighborhoods now, or do you want to go 5 asks? Which one? I've got them both.
Let's go for the neighborhood. Let's go for 5 asks. So this was probably the most popular session, I'd say, in terms of the feedback and all the other stuff that we had. And I think this is a problem that many people are keen to figure out and address, which is the primary care interface. Do you want to talk a bit more about it, Andy? Because you were actually leading the session, weren't you?
Yeah, so I was leading the session, and we had Hussein Gandhi, who's our place-based partnership
Same emoji.
director. Hussein Morji. No, you're Hussein Gandhi. Yeah, you do many jobs, but not that one.
No.
And Thea, De Beer, who's one of the deputy medical directors at Nottingham University Hospitals, our local acute hospital trust, and they have done a lot of work about the interface between primary and secondary care, and improving how patients and patient information flows, and reducing friction between general practice, primary care, and secondary care. Because let's face it, there can be a lot of friction and things can go wrong. And
definitely,
this is a scheme designed to create a feedback loop to educate the hospital when there's been inappropriate work transfer to primary care, and it's been developed. I think we'll play a bit of the clip here, and Hussein will probably explain. But I think the key to this intervention that they discussed is that it's been developed in collaboration. So it's not GPs sending angry letters to the hospital. It's the hospital have agreed to receive letters in a certain format and to process them and to take the correct action. And all the hospital departments have agreed to receive that. And there is some governance that sits over and monitors what happens, and is looking for key themes in terms of what's happening. And then those themes can also be addressed as well as the individual issues. Let's play a little bit. And if you feel we're going too long with this one, Gandhi, just stop us, and hopefully people can hear the audio.
If you think about the national and the BMA contract letters and the LMC contract letters, they're absolutely spot on in their content, but they're not very friendly, and they do tend to generate a little bit of ill feeling. Consultants
getting a little bit of feedback, Andy.
What's all this nonsense? Why are they sending these horrible letters? But actually, the 5 asks letter we do.
How about now? Is that okay?
What the 5 asks are? It's signed off by the LMC, by the ICB, by general practice, and by...
I've turned down my volume, so I can't hear you, so you have to wave when we're all done.
And it reflects the strength of the partnership. We are working together. You've not quite done this right. Please, will you sort it out? And the other part of that is that if we do nothing as a hospital team, then stronger imposed approaches may be needed. And so there is an active ask for the consultants to do this properly and for their resident officers to do it properly. And what happened is that once we'd refined the letter, and I think we went through 19 iterations of the letter to try and make sure it was sensitive enough, the hospital then spent 3 weeks cascading that down to all their teams. Thea and her colleagues did a great job of that, and then we implemented it in, I believe it was November. So we now have a really quick and easy mechanism where I can hit F12 on my, we have an IT solution called F12 locally, where if I hit F12 on my keyboard, it brings up lots of referral forms and pathways and data. And one of those is the 5 ask letter, which pre-populates with patient details. I just put in a couple of lines about what's gone wrong, and then it gets emailed off to the hospital. And John Peach, who's the director of ops at NUH, looks at all of these requests, makes sure they go to the consultant, and makes sure they get acted upon. And since November, I think it's now just over 400 5 ask letters have been sent, and the vast majority of those have been resolved by the hospital. So it's a really good way of feeding back, a really good way of getting the work done properly, a really good way of reinforcing the message, this is your responsibility, but also enables us to generate some rich thematic data about those specialties, those teams that are repeat offenders, which enables the hospital to look further into why that's happening.
I just wanted to give a quick reflections as a local GP working within this system, and about 5% of those 405 ask letters are probably for me alone, to be honest. It works.
We know.
He knows. But it works. Out of the response I've sent, every single response I've had has come back within a week or two. So that time frame is really important. And been supportive of the patients, and been really effective. It's not always perfect, but it works so much better, I think, than what it used to be. And the recognition that there is that interface and that engagement from both sides, I think, is a really powerful thing. So that was the kind of full version of the video that we played. And if you want to see the full content, you will need to sign up at the actual for the conference, and that is ability is still there for another 9 days, I want to say, if you want to do so. But I guess part of that conference was talking about various different aspects, wasn't it, Andy, in terms of PCNs, neighbourhoods, and various other aspects in healthcare and primary care.
Modern general practice. And there was also a quite impromptu and unscheduled discussion about AI, just indicating the I guess the need out there to have conversations and create spaces to talk about AI, because it wasn't even on the schedule, but we spent quite some time during the introductory discussion actually talking to delegates about AI and taking some questions on AI, which I guess is why we've thought actually that's triggered us to talk about another theme here today, which is AI in general practice, because there's been a few stories in Pulse and floating around about AI, and there's also been some guidance published by NHS England around that as well.
Absolutely.
So I guess the first story sort of leads into that guidance quite well. So GP liability warning as Health Secretary pushes use of AI in NHS. So this actually relates to the publication of some guidance about how to use AI scribe technology effectively in general practice. But it sort of generated this story in Pulse, which focused on the liability aspect of using AI and where that might land. I guess this story talks about that guidance has been published, talks about the aspirations for this scribe technology, which is outlined within the guidance, and really about saving GP time from typing and recording information and documenting, so that time can be used to pay attention to patients' needs and deliver care more effectively, and also potentially improving the quality of that documentation. I'm sure we'll have some more to say about that when we start looking at the guidance itself in a few minutes. However, it does also highlight some of the potential problems with AI products, such as high potential for bias due to limitations of data and processes used for AI training models, and highlights that there might be some risks of output errors as well, and also potential risks around data usage and data lost. Also talks here, and I think we'll probably talk about it in the guidance, that that practices should run a clinical hazards log in order to monitor the safety of the product. And the key thing here is on liability risks. They say NHS organisations may still be liable for any claims arising out of the use of AI products, particularly if it concerns a non-delegable, so a risk that you can't delegate, duty of care between practitioner and the patients. And it talks about potential financial exposure to risks that might be mitigated by contracting arrangements, but it still feels like it's a little bit of a grey area, at least after reading the article. Again, I guess you've had a look at the guidance itself, which I haven't had a chance to look at, so I guess I can react live as you explain some of the aspects of it. Do you want to go there next?
Yeah, let's go to it. So this guidance, so the links for this is down below in the show notes if you do want to go to it directly. It's not too long. I think it works out about 7 pages in total as the document. And it basically talks about the scope of what ambient voice technology, which is the kind of term used within the document to talk about scribe AI, or, whatever you want to call it. I know I like calling it scribe AI, but I've got a reason for calling it that, which is the lovely acronym I've created for it. But I think it's a good, clear document in terms of some of the information that's there. There's still some ambiguity, but one of the key things it does talk about is the process that you need to go through in terms of assessing ambient voice technologies, how you may start to include using these in healthcare, and then key points to be mindful of when it comes to assessing the technologies, using them, and that kind of stuff. It's got an implementation guide, which is really useful, which is that number 1 section that you can see there. And it probably worth just going through the headlines of that, if that's all right, Andy. So as you can see on screen, so number 1, the first thing it says to have at the top is to have a clinical safety officer. So if you just scroll a little bit high, Andy, I think you just passed it.
Are we dealing with a lag here?
Yeah. Possibly, yeah. So assign a clinical safety officer and identify the risks. So this is possibly something that many practices aren't aware of, but ideally you should have a clinical safety officer, particularly when it comes to the integration of technology into your practice. There is specific training around this. I think it costs about £500 if you were to go to become a trainer, and it's different to your Caldecott Guardian role. That's the key thing. It is a separate role. But it's about having the information, hazard logs, various other things that feed into some of the other stuff we're about to talk about. But I guess for me, since most practices probably won't have this in their practice, unless you're a really, really, really big practice, it may be worth talking to your local federations or your PCNs. These are organizations that might be able to have these kind of roles to support you in terms of understanding.
So again, we can share clinical safety officers with across organisations and with other organisations.
I believe so. So there's nothing that states it has to be specific. It's not like the Caldecott Guardian where you're mandated to have a role. It's recommended, and this could be somebody kind of like probably more akin to a DPO kind of role. I'd probably say is a better way of thinking about it for many of those in practice. So somewhat, a role you could potentially import from elsewhere. It's just recognizing there's somebody responsible for the safety of the use of the technology within the practice or organization that you're working with, or the provider of the technology itself. It then talks about completing the DCB 0160, which is a certificate, which is effectively a risk assessment. And that also includes the DPIA, which we've talked about a few times in some of these technologies about completing it and things. And again, these are often certificates you can work with the providers to help do that. You can technically even use things like ChatGPT and that kind of stuff to help form the start of this and stuff, so you can analyze them. There's some really good resources.
Are they long documents, Gandhi?
Yeah,
Are they challenging to complete? Okay. And
They,
is there the scope? Is there the
they
scope for it to be done once within a primary care network or a place or an ICB, or does it really need to be specific to the practice it's deployed in?
So I think one of the reasons why there's this often comment about people not using particularly ambient voice technology is because a lot of places are hoping their ICBs will do this, so their ICB IT department will do it for them. And then the whole point of that is that, well, if the ICB's done it, then we don't need to do it. But important to recognize there are some subtle differences that may come across in terms of individual organizations. So depending on what technology you might be using, there may be some tweaks you need to make based on the technology you're using, because that might have a governance risk in terms of what you're, how you're using that particular technology within the practice. For example, how does that work with your telephone system? All those kind of things. Is there additional aspects you need to factor in? For ambient voice technology, I don't think there's a huge amount of that. I think if you're doing, for example, your digital influx triage, your electronic health record, they're much bigger things that absolutely have more of an impact in terms of how that works, because they work with every single part that you do. But I think, those certificates are something that they recommend that you should have looked at. And I think that's the key thing that many people who are working, I guess, within the health IT community keep trying to identify it. Although they are things you should do, they're not necessarily barriers to stop you using the technology. It's just checkpoints for you to make sure you're using the technology safely. Does that make sense?
Yeah, it does. And it's really nice actually to have an implementation plan sort of spelled out, really, because I think a lot of practices will not know where to start, either in terms of going through the process or just understanding what it entails to see if it's actually a process that they're able to engage with at the moment. Yeah, it's great. Take us through some more of the points in the implementation plan.
Yes. So then it's about how does that integrate within your systems, and a lot of that you will figure out by doing, for example, the DPIA. Once you've done that, you'll understand a lot of the workflows and things that comes across. Then talks about appropriate controls. So who should be using the technology? How does this work within your practice? What actions are you going to use from it? What do you not want to use? So how are you setting that out? And then having a framework to manage that. So effectively creating your SOP between the two aspects in terms of what that will look like for your practice. What features do you want to use? How are you going to use them? All that kind of thing. That needs to be an assessment. And then it specifically talks more about Ambient Scribe itself and what the product is. Now, I guess just for those who don't understand what Ambient Scribe is, it's basically a technology that listens into a consultation and uses two different forms of AI to manage effectively the output. So the first one is it listens and transcribes the consultation. So it uses a form of AI to do that transcription. Okay. And then using that text, it then anonymizes it so that it takes out all the patient data, and then uses a second part of AI to create the summary. And that's the part that a lot of people are still unclear on, even to a degree in terms of the guidance as to where that sits in terms of medical regulation. And that's the one thing that I think a lot of people are keen to understand in more detail, because of the level of medical regulation you put onto these products changes how much detail, how much work the companies need to do, etc. There's a growing trend, I think, from a lot of this that the ambient scribe technologies are going to come out as an MRHA level 1 piece of equipment. So that means that they basically help to provide some information, but don't necessarily make a decision about what the clinicians are doing. However, if they were to start doing that, so for example, if they suggest a diagnosis and you were to then use that, is that touching into a higher level of regulation, and then the impact that will have? And that's where it talks about a little bit later down, I think it is, in terms of the technology.
Yeah, that's really interesting, because I guess a lot of people will have used dictation technology for a long time.
Yes.
And I guess that's the first bit that you were talking about. And then the second bit is where it processes that and gives you outputs which are different to the inputs that you've put in. This table's really useful, isn't it? In terms of just saying the sorts of things that this might help with. I don't know if it's with just saying that actually, how this might be more helpful than dictation, I guess, for people who may not be familiar, or just to give your current take on it, Gandhi.
Yeah, so I mean, the input side of it is, like you say, is capturing, first of all, the recordings, which is what a lot of dictation tools will do. And then it incorporates the information potentially that you've given it in advance. So a lot of the platform tools will allow you to, for example, to put context into the information, so that can then help it figure it out. And then the outputs, then come out in terms of different forms of output. So you can, control the style either by using templates or, shorter, longer, that kind of thing, bullet points or text based. And then do you want it also to then do further outputs? For example, convert that consultation into a referral letter to send on to another service, and you're not having to spend that time formulating those letters. That's potentially where the real gains are, because I'm sure you've done it, and I'm sure many clinicians watching this have done this, that when you've done a consultation, then just to start to write that letter, even if you were to dictate it, you still have to formulate it in your mind, figure out what you're going to say it, maybe try not to revise it too many times, because sometimes you may think, oh, I need to add that bit in, I need to go back and do that, was that what they said? Were they on that particular dose of medication? All those things, that's suddenly gone. A lot of that is done for you. You absolutely need to check them, but that's where the time saving comes into play.
Yeah, that sounds really game changing, for a lot of people actually, and that is something entirely new that I've not seen before. And seeing some of the demonstration of the technology, it is really, really impressive. So I can see how there's a lot of potential in these products. Do you want to, Karen, take us through the document, Gandhi? Anything else?
So it then talks about the benefits a little bit lower down. We've talked about some of this in terms of the administrative burden, particularly it can help reduce, how that could be used in terms of different practices, in terms of documentation and time saving from that. It focuses a lot on that. Should we get a bit lower?
Yep.
Maybe we do have a slight lag then. So then, it talks about the risk assessments, which we briefly talked about. So there's two different ones to be mindful of. There's the DCB 0160, which is often done by the practice team. And there's the DCB 0129, which is done by the provider. So, the supplier of the technology. Those are two separate documents that do need to be done. And that's in addition to the DPIA, which is the actual risk assessment. So hopefully that's helpful to many people to understand and that information. And talks about regulatory and compliance, which I can't quite remember all the details on that, I'm afraid, without reading it.
Yeah, and people can, of course, engage with this document themselves. I guess we're just familiarizing people with the contents. This was interesting, Gandhi, above, but be mindful that. So I guess the products might introduce new functions unintentionally and can introduce unique cybersecurity challenges. I guess they're kind of covering bases there in terms of things that might happen with the platforms that they don't anticipate. As a user might be able to provide instructions to get the product to generate an output that goes beyond the product's intended purpose, even if this is not the user's intent. That's interesting. It makes me think about these 1980s movies like War Games, where Matthew Broderick unintentionally gets the AI to nearly start thermonuclear war. It's just interesting in terms of its warning is that it might do something that it didn't intend or that we didn't intend in terms of generating the output. So really interesting. I guess maybe they're referring to biases, or sometimes these large language models have started exhibiting strange behaviors, haven't they, depending on the data on which they're changed. Well,
there's that whole question about bias within AI, isn't it, in its first place? But I guess there's this aspect of, once the data's out there, you can't bring it back, you can't delete it. For example, it's off into the the AI system, the large language model, the internet, whatever you want to call it. Also, I guess when I first started playing with some of these platforms, you could ask it to put the output in the voice style of Donald Trump, for example, and it would do that. And that's not and that's not really a great way of doing documentation. There's that question of is that appropriate for it to work and things. So just recognizing these changes that it can have and stuff, shall we scroll down further?
Yeah, of course. Tell me what you want to sort of focus on, Gandhi, as we go through.
If we go a little bit further down.
Liabilities area I'm interested in particular.
Yeah, I think that's a bit further down, isn't it?
Monitoring and bias mitigation. I guess we've spoke a little bit about bias, but it says AI-enabled products have a high potential for bias due to limitations in the data and processes used for AI training models. So I guess it's really just warning us that as we keep a human in the loop, a human monitoring the outputs, that these are the sorts of things that we might expect and need to be aware of, I guess.
Yeah, absolutely. So actually, I wanted to talk about user training. So this, I think, is something that's really important for people to recognize, that you should have an SOP, a standard operating procedure, to help you understand how to use this, and a training matrix of what that looks like for your team to use. And the reason for this is it comes up to the liability aspect. So there is still liability held by the clinicians in terms of using these technologies. A lot of them reference the fact that when you put the information from the product of the consultation into the patient's notes, you are still responsible and liable for that information being correct in terms of when it's added to the patient record. I think that's a question when it comes to integrated tools as well. So I'm in a weird smaller camp, I think, that I don't necessarily want these tools to be directly integrated into my EPRs, because I think that reduces the chance of people checking the information, because when they're not integrated, you physically have to move it from one place to another. And that step of moving it just potentially adds as an extra step for you to think, I need to check the information. Whereas if it's directly integrated, I think from my perspective, we could end up in a situation where some people get so used to thinking it will be fine, they click across, forgetting that these tools can and will hallucinate sometimes. So put incorrect information in, and therefore they haven't checked, and they're responsible and liable for having put that information across without checking it.
Yeah, I suppose it's helpful to maybe have buttons and warnings within the systems, to say like click to say that you have checked, and I guess to remind us where those boundaries are around liabilities. I don't know whether those do exist within the systems. I've not necessarily seen
quite
that,
a few of the providers are putting safeguards in place. So, for example, one of the things is if you haven't edited the output in any way, shape, or form, it'll ping up a little pop up to say, are you sure you've checked it, kind of thing, or something along those lines. Whereas I think the transfer mechanism is more of a fail-safe in my view, but I appreciate I'm in a smaller camp that think that. I think more people like integrated tech that works with click of a button and stuff, but I can understand absolutely why.
Yeah. I think something that reminds you of where those boundaries are would be useful, I think, for me. It's interesting. Do we have an understanding of what a non-delegable duty of care is? I mean, the way I imagine this works is, we are registered health professionals and we're responsible for obtaining the right information from the patient within the consultation and the rest of the medical record. And then we process that. And I guess these are technologies that are helping us process and, document and manage that information in the way that we normally would manage that information. And then we provide an output, don't we? A management plan, prescriptions, actions, and then we are responsible for the actions. And it's really just that information management that it's helping us with. Is that probably the right way to think about this, Gandhi?
Yeah, no, I'd agree on that basis. Yeah.
Okay, that's really helpful. Okay. Good.
So then it talks a bit more deeper considerations, a bit more information about the different aspects. And as ever, we always talk about the key information is often in the appendix, isn't it? So where are we? Just scroll down a bit further.
Yeah, there's box 1 that we're in now.
Keep going.
Yeah. Be aware of the lag.
Yeah, that's what I'm just trying to check for. So here it talks about, be aware of the following challenges regarding the outputs. So I think, just a little bit higher up. It's A211, I think it is.
I'm there already.
Okay, yeah, sorry, everyone. We seem to have a bit of a lag with what I see on screen, what Andy delivers on screen and stuff. But yeah, just talking about the accuracy, talking about the contextual understanding that AI can make errors based on context and stuff, and that obviously may not have all the information at hand and therefore can have gaps as a result of that.
Okay. I'm actually, having reviewed this with you, Gandhi, I'm actually feeling a bit more confident about the prospect of this being used within my practice. I can see how this guidance is actually really needed and helpful at this point as people are beginning to adopt these technologies.
Absolutely. I think, it's really good guidance. I do actually quite like it. I think it has covered a lot of the stuff quite appropriately. This box is the one that talks about medical device regulation. And I think it's, that paragraph there, ambient scribing products form. Sorry, I'm dealing with the lag. Don't know why we've got a lag. We don't normally, do we?
No. Nonetheless, it's there.
Yeah. So it's halfway down in that box too. I think it is. It's the second to last paragraph. I think it was.
Here we are. So I think we've got ambient scribing products that inform medical decisions and have
Mm-hmm.
simple, low functionality. For example, products that solely generate text transcripts that are easily verified by qualified users are likely not medical devices. So I guess that might cover some of the uses that we've sort of been talking about today.
However,
the use of generative AI for further processing, such as summarizing, would be treated as high functionality and likely would qualify as a medical device.
And then further functions involve providing a call for action or prompts for feedback, suggestions on the consultation. Functions that generate clinical codes, letters or health records, or inform the clinical decisions. Any related processes may qualify as a medical device as well. So it's those additional functions that do qualify it potentially as a medical device, and it's that question of what level. And I think a lot of people think it will definitely be a 1. So ideally, if you're using one of these products, they should be classified as a level 1 MRHA medical device. Question whether it comes out as a 2A, which is the next step up. That's the one that people are still unsure of and waiting for more fuller details.
Gandhi, do most of these products have that level 1 certification at the moment?
A good proportion of them do. There are some that don't, some that are still in that process of getting that certification. So I think for me, at the very least, if you wanted more certainty, particularly if you're looking at mass integration in practices, yeah, it needs to be at least a level 1 product. And I think there's 3 or 4 that currently have that certification already.
Okay, that's really helpful. It feels like that's something that could be a bit more explicit and higher up within the guidance in my mind. But I'm glad that we've highlighted that.
And I suspect that's stuff that things like CQC will look at. So they'll probably look at, if you were to be inspected on this basis, then, there's a question of, have you done your DCB 0160? Have you done your DPIAs? Have you got your training programs in place? All that kind of information. That stuff they'll be looking at to see whether or not you've gone through this process to assess, is this technology safe? And obviously the key one, are you consenting the patients when you're using this as well, which is the other aspect, because this is about recording patient data, regulation, etc., and having that information at hand. So there's still the view, I think, that you need to consent the patient at every consultation. It can be a really quick process. I know I find it is. My standard thing is, and I'm using an AI tool to help summarize the notes. Are you okay with that? If they want more information, I'll expand from there.
Okay, good. It looks like box 3 is really, really useful for talking through how this affects CQC or how CQC interact with this issue. Good.
And I think that's most of it, if I remember rightly.
That's really, really helpful. That was really, really helpful, Gandhi, and I hope it's been helpful for people out there. We've got a quiet crowd tonight, so do let us know if you're enjoying the show episode this evening, and if you have any comments, or if you're using any of this technology yet in practice. Have you done the relevant assessments that have been suggested, and how are you finding it? I guess you don't have to answer all of those questions, but I encourage you to answer some.
But I guess if you want a support in terms of that training tool and things to consider when you're looking at that, we've also got some content to help you do that on the GP Learning channel, in particular, the Scribe AI video that we've got, which I believe is on the thumbnails, Addy.
It's here. We've got you in a nice pose. There we go. There we go.
Yeah. So this is just a short video going through some of the key aspects to consider when you're doing a consultation. Hopefully that can form a part of the training package for people if they want to use that as well, or make their own version now.
All right. Fantastic. That was really helpful. I guess we've got a few stories that we picked out from Pulse over the past few weeks, because there were a flurry of stories around AI, possibly what's the word, primed by this story. So just a few things that caught my eye, really. So there's AI scan of patient records could boost early lung cancer diagnosis. And I thought this was really interesting. And this concept of an AI scan of patient records is something I've not heard too much before. I think people have used similar approaches to, identify people at increased risk of admission or attending A&E, for example. So I guess the concept isn't new, but just this idea of an AI scan. So I can see there being perhaps a flurry of similar products or services coming. So essentially, there was a story in the BJGP actually, which is what this is drawing upon as its source material. Some Dutch researchers have developed a tool that can that looks at the free text and coded text within patient records, and can provide an early warning of a patient's likelihood of having lung cancer. So if we just look at what they did, so to develop the tool, they've analysed about over 500,000 patient records. About 2,400 went on to develop lung cancer. It looks at both free text and coded and structured data, and the team found that it adequately referred 62% of all patients with lung cancer at around 4 months earlier than had been done by their GP. And in terms of a number needed to treat, they had to apply the test to 33 patients. 33 patients would need to undergo the test in order to identify one new case. So I think this is... It's people may want to go away and read the paper. I'm just realizing I'm raising questions in my own mind about the stats, which I'm sure people will also want to ask as we're going through. Essentially, they conclude that this serves as a sort of proof of concept. Further analysis would be needed before this is deployed, particularly in different countries and different healthcare systems. So it looks like this is Dutch research, but promising development, and made it into our industry press via the BJGP. Any thoughts about these technologies, Gandhi? I guess we'll just see more and more of these as we're running more and more of our data and outcomes through AI systems, looking for these connections.
I mean, that's one of the key things about data, that AI, isn't it? It's really good at crunching data and using that, for example, in terms of particularly radiology. It's one of those systems where it's pattern recognition. It's about analyzing the data and then processing it and stuff. And potentially, if you train it well, it can be quite accurate and helpful in that sense. But I think it still requires that using the term as a scan to kind of figure out what you need to start with, I think is always a good way to go.
Yeah, absolutely. And lung cancer is a really good place to start.
Yeah,
I guess there's 80% mortality within 1 year of diagnosis. Isn't there currently? So earlier diagnosis would be really, really helpful.
absolutely.
We've had a few comments. Do we want to go to some comments?
Shall we just do the other story and then lead on to from there, if that's okay?
Yeah, go on then. That'll move us on.
Give everyone a little bit more time to stick their comments in.
Get your comments in. Some good comments about AI scribe technology that I can see. And then another AI story in Pulse was so this was just highlighting. I found a previous story that was an example of using AI to an AI scan to identify people at increased risk of attendance at the ED departments. That's a story from the tail end of last year. So AI skin cancer triage given conditional green light by NICE. So that's for further evaluation. So this is looking at an AI-powered system for detecting potential skin cancers. We'll have a look at the NICE ruling in a second, because it's nice to look at sort of the AI technology assessments and just have a look where they are and how they work. But it's been approved by NICE for use for 3 years, while further evidence of its effectiveness is collected. This technology sits as part of urgent dermatology referral pathways in the urgent teledermatology referral pathways. It's called deep ensemble recognition of malignancy, which conveniently the letters are DERM, derm. So that's really convenient, isn't it? And as I say, so it's normally used in sort of teledermatology services. So that's the intended use. A picture is taken using a smartphone and a dermatoscope, and the company report that they just looking at the number of images. I've not captured that, but basically it compares with a large data set based on images of skin lesions, and it's a really high number in terms of the training data that's been used. Company's data from use in NHS services so far collected between 2020 and 2023 showed that automated derm has a 97% sensitivity for detecting cancer lesions in those submitted, and a 95% sensitivity for detecting melanoma. Oh, it was about
Wow.
86,000 lesions. So they do think that it's a promising technology. Just
Mhm.
popping on screen, just so people know and they can browse perhaps some of the other ones that are there. But nice, have an area within their guidance for technology, so you can navigate there. I think looking at the technology evaluations are also going via the areas, and they give you the recommendations. And I can kind of see how Pulse constructed their story, because they've clearly looked at the recommendation area in terms of constructing the story that they've done. It's nice going to the source material. You can see how the journalists do it, really. And so it discusses the recommendations, and further evidence that's needed going forwards. Yeah, so interesting. Yeah, any thoughts about that, Gandhi? Or have you? I don't think I don't think they're using that locally within Nottingham, or not that I'm
No.
aware of, unless you know any different.
Come across colleagues who are looking at doing similar across the country. So I think one of the Twitterati colleagues of ours, or former Twitterati colleagues, Craig Nicklick, has been trying to pilot some similar program down in South and things. Reason I remember that, I happened to meet him at the ASMA conference as well, which was kind of cool. But yeah, I think there are examples of this across the country, and potentially one of the areas where this can be really quite powerful and things. Little tidbit as well, Andy. I don't know if you remember, the original reason we started this channel was looking at the nice technology guidance on apps that they were approving way back when we started doing all this podcast, 7 years ago.
That's true. I mean, apps were the big thing then, weren't they? And it's not, things haven't really gone in that direction in terms of apps being as big as maybe we and people thought they would be at the time. But there's all sorts of other technologies that have come along in the meantime, and AI is the current, I guess, most promising, most discussed one.
Absolutely.
Yeah, good trip down memory lane.
Absolutely. So we've had some comments come through. Let's go to those now, because they're going to lead in potentially with some of our other stuff. So first question we've had, a comment we've had, is from Guy and Pereira. Do all these steps need to be done before you start using the Scribe AI, such as Heidi, or wait for the PCN, etc., to do so? Now, I'm going to be quite clear on this. I think you should have done these steps before you start using these tools in practice, because they are safety steps that actually inform the process and the way that you use them in practice. It's kind of like, doing all your person checks before you have a locum start working the practice. It's not that dissimilar from that point of view. The fact that you can technically just log onto a computer and start using these tools without having done all this stuff, I think is a decision for each clinician to make. But like I said, my recommendation would be you should have done all this before you start using them.
I think, and now that the guidance exists, I suppose it's harder to defend not following guidance that exists. I guess it was easier when the guidance wasn't there. So I think if we move in this direction, we'll be referring to this guidance, and actually it looks fairly usable, which is really reassuring as well.
So next we've got from Jayesh Puri, just jumped on. I've been using Heidi for a few weeks and love it. Did a demo to my partner this afternoon. Just a lot of apprehension when you mention AI involved in patient care. Absolutely agree, which is why there is this safety process in place to try and help understand and inform some of those decision-making things. Shout out to Jayesh, who happened to join me for my live stream when I did that on Tuesday live from the Accurx conference, because I know he made a comment on that. So definitely thank you for joining us again today, Jayesh. And part of the reason I haven't brought some of the other comments on is because they make reference to the big Tandem AI Accurx announcement that came out at the conference, which I think Sarah's qualifies a really interesting summary. Thank you, especially after the Accurx product announcement. Have you heard about this, Andy?
So I've heard about it. I don't know all the details, so it may be worth telling me and other people again what's happening with Accurx and Tandem and what that's all about.
So Tuesday was the Accurx user conference that they call Accurx Connect. I was really happy to be invited to come and speak and stuff at that conference and things. It was a great event, really nice. And the big announcement that came out of that is that there is obviously some product development going on, but they've gone in partnership with a company called Tandem, who provide an AI scribe tool. And that tool will become available to all Accurx users for free for a few months. Pending further information coming down from the ICBs and that kind of stuff, but available for people to use in practice and they will support you with a lot of the stuff like the governance, like the documentation, the DCBs, all that kind of stuff to help get that over the line, pending your local ICB arrangements. So there is some things to be clear on and stuff. And if you want to see some more of that information, that is absolutely on the channel. I think I've put out like 4 videos in the past 24 hours all around the Accurx conference. So if you want to have a look at what the actual demo is, how it works, interview with Jacob Haddad and Dr. Katie, who are the two have kind of spearheaded this deal across the England and things, then absolutely feel free to have a look at that detail in more content, content in more detail, and see what it throws.
Yeah, exciting. Exciting times, and it's good to have a lot more options for people in terms of what they think will fit their practice and their patient population well. So that's really, really good.
I guess just an extra comment we've had from Sarah W again. So I think this was more in relation to the scan stuff. We're really interested to consider how this could improve access to info held as free text. Now I'm taking this is in the concept of having an AI scan tool to scan the patient record and get you the free information, free text information to you to summarize that in terms of patient. Imagine how cool that would be, because patient records potentially could be massive. We're talking thousands of entries to summarize and navigate through, and actually having a tool to help you do that, that's the dream, isn't it, Andy?
It is. I mean, in my use of large language model technologies, I think that's really what I'm doing in many ways. It's sort of an enhanced search function in some respects, asking a particular question and receiving like a really bespoke search response. Sometimes you ask it to generate things, and that's why I guess we call it generative AI. But a large part of what people are using it for is to just summarize really big pieces of information or big sources of information. So being able to pull relevant information from huge patient records and surface that within the consultation more quickly and more accurately than we do or are able to currently could be pretty game changing. So yeah, I'm quite excited about that as well, actually. Imagine if that was contextual, if it kind of judged the context of what was happening and what the differential diagnosis might be and pulled out the relevant information. I mean, it's certainly doing a lot of work for us.
Definitely a medical device.
Definitely a medical device there if it's doing that. But it's really exciting to think where these products could go in the future.
Yep. Absolutely. So I guess there are other products you may also want to consider using. At this point, probably would love to signpost you to one of the ones that we know is quite awesome and quite helpful for you in general practice. So why don't we hear from 2 other guys you may have seen before?
So, Gandhi, while we're taking a break on the sofa, I've got a question. Our practice has been looking for ways to make things run better, more efficiently, improve patient care, and ideally to make a little bit of extra income as well. And I was wondering if you found anything that actually helps.
Yeah, so we've been in similar situations. Managing long-term conditions taking loads of time. So, there are various tools out there, and the one I would definitely suggest to have a look at is Primary Care IT. It's made such a difference.
And so, that's interesting. How does it fit into and work with your existing systems?
Well, that's the cool thing. It integrates with all the clinical systems that we've got currently, so TPP, EMIS, and Medicus as well, if you've got access to that. And they work really well rather than adding that extra step because you can launch them through the systems.
And I've heard about the Accurx 3 calculator. Do you use that?
Yeah, so I know it's already built into EMIS, and they're looking at TPP integration soon. And then the benefit of having that straight away is the fact that it's integrated straight away. You can get the risk scores without having to switch back and forth between all the websites and the other kind of tools and stuff that takes so much longer.
Oh gosh, that is a headache. So I'd love to avoid that. Sounds really useful. But what about support? New tools can sometimes be more hassle than they're worth.
Definitely, but I think their support is really solid. They have loads of onboarding support that you can have, webinars, resources that you can access as well through their website as well, and regular contacts that you can use.
That sounds really good. Sounds like something that we'd be interested in as a practice. How would we get started?
Well, I'd definitely check out their website. It's primarycareit.co.uk. That's basically where you get all the information you need, their contact details, as well as demonstrations of what they can do for you in practice, and also what's coming soon as well.
Oh, fantastic. We'll get started.
So definitely big shout out to Primary Care IT. Great tool, great stuff coming up. I know they've got loads more planned for everybody coming soon as well. So definitely check them out. And the links to those are down below in the show notes, as well as you can see, just search for Primary Care IT. Okay.
So moving on to our next segment, really. one of the other big talking points at the PCM Plus conference was around neighborhoods. There's a lot of talk. It's got a high profile in lots of the planning documents, policy documents that we've been seeing coming out really back from the Fuller Stocktake and before. And I think we all expect neighborhoods to be a big part of how we're working in the future. But yet still fundamental questions remain unanswered. What is a neighborhood? And how will this work? We're really waiting for the 10-year plan. But we had a really good discussion at Primary Care Plus about it. And also NHS Confederation have released a new document about neighborhoods a few days ago on the 29th of April. That's a really good read as well. So we thought we'd just spend a bit of time talking about where we're at with neighborhoods. Shall we play Ben Gowland, our co-collaborator, podcaster? We've got some video of, I see, Gandhi, you were just concerned, weren't you? Somebody said, is it me or has the screen frozen?
It doesn't look like we have, so hopefully we'll be able to hear this all right. So let's get cracking with this. And they just need to make sure your speakers are off.
To be focusing on neighbourhoods. So neighbourhoods have come out as like Labour have been talking about moving the NHS to being a neighbourhood health service. And whilst we don't know the details of what's going to be in the 10-year plan, it's pretty clear from the planning guidance and everything that's come out that neighbourhoods are going to feature front and centre. You probably saw. Let's see if you did. Who has read the guidance that came out in January on neighbourhoods? Well, I'd say about half the room. Looking at the room there, which is pretty impressive. You will notice that it didn't define what a neighbourhood is in that. So there is that kind of fuzziness that might be helpful for us to explore. So the way we're going to tackle this session is we've got some great speakers here. So we've got Kira Stewart, who's a Deputy Place Director at Nottinghamshire ICB, and Rich Brady, who is the Director of Strategy and Partnerships at Nottingham City. Now, what they're going to talk about what they are doing locally with neighbourhoods, so we get that feel. And then we've got Dr. Duncan Gooch in his first public outing in his new role as the chair of the Primary Care Network at the NHS Confederation. So I'm going to be grilling him about, okay, what does all this mean and how do we make sense of it? So he's looking forward to that. And then we've got time, then we're going to have a wider group discussion to try and get into it. Okay, what do we mean by neighbours and what does it all mean? So hopefully it's all going to fit together. So
we're back.
Yep, we're back. And if you want to watch the full section of that, then like I said, do log on to PCM Plus 2025. The recordings for that are still available if you wish to access them. And if you attended the conference and didn't get to see that part, like I didn't, unfortunately, I was busy running around in the background sorting stuff out, then absolutely go back and watch it and things from there. But yeah, one of the key things that came out since then is this document by Confed, which is where Duncan Gooch, I believe, now works as the head of primary care networks, about neighbourhoods, doesn't it, Andy?
Yeah. So Duncan was the chap sat next to me on the video, second to far right on the screen. Interestingly, I went to medical school with Duncan, and now he's NHS Confed lead for neighbourhood working. So that's quite exciting. He was quite new in role, and he had a really difficult interview with Ben, actually. The opening question being, so Duncan, easy question, what is a neighbourhood? And Duncan actually found that quite difficult to answer because it's not really been defined very well by the system yet. But let's have a go and see where we're at with neighbourhoods. I think, Gandhi, just before we look at NHS Confed report, just to, I guess, remind people of just the headline themes from the neighbourhood health guidance that came out at the end of January, because I think that was before the NHS, and from NHS England, I guess that's the most sort of concrete thing that we've had around neighbourhoods. And I guess to summarise it, I would say there were sort of 3 shifts, 3 aims, and 6 core components. And so those were the 3 shifts that we're all familiar with. So it's neighbourhood supporting, analogue to digital, hospital to community, sickness to prevention. They described 3 aims for neighbourhoods over the next 5 to 10 years, which were NHS and social care working together, strengthening primary and community-based care, and connecting people and actually connecting all sorts of elements together more effectively. And then they anticipate 6 core components of neighborhood working and teams, which is population health management. So that's, data tools, and cohort work, essentially. Modern general practice they see as a core component, which is interesting. And we had another big session on modern general practice at the conference as well. Standardization of community health services, neighborhood multidisciplinary teams, so MDTs, integrated intermediate care with a home first approach, and urgent neighborhood services. So as well as for, anticipated and routine care, moving towards urgent neighborhood services. And they mention examples such as urgent community response. So I'm thinking of the sorts of social care services that we have available in some quantity, to keep people out of hospital. They also mentioned virtual wards as well, and they mentioned the concept of single point of access. So just interesting that people can go back to that guidance and have a look at those kind of core components. And the NHS Confed document complements those really. So what have Confed done? So they've released this paper, Resetting the Relationship Towards a Social Model of Health Creation and Care, but exploring what a neighborhood model of healthcare could look like and how to embed it in the NHS. And what they've done is they've got a group of experts, an expert panel, to do what they call a policy sprint to anticipate where we might head with neighborhoods, to produce some elements and some guidance to NHS England and ICB ahead of the publication of the 10-year plan, to try and steer the direction of the development, and also allow people to prepare for what's coming. I guess I'll just kind of summarize the main elements, Gandhi, and then maybe we can see what you and other people think about how this affects plans that might already be in place in their places, working towards integrated neighborhood teams and neighborhood working. So they set the scene and they talk about the background. So there's demographic change and shift. People are becoming living longer, becoming more unwell, having increased care needs within their lifespan, and also the sorts of problems and challenges that we're dealing with in health and social care are becoming more complicated, more multifactorial, and actually the causes of many of the challenges that our patients face don't just sit with social care, don't just sit with health, but they are multifactorial. And actually, in order to solve these problems, we do need to shift to a more integrated way of services and community voluntary sector working together. So they really set the scene, and then they describe the policy sprint that they've undertaken. They identify 4 kind of key elements for moving forwards. So they talk about trust, that this all needs to be based on trust between services, between communities, between health and social care, and place an emphasis on really valuing that trust, and that it's really going to be necessary to invest in developing trust and relationships. They talk about more consistency, and in this section, they actually say often neighborhood models are kind of brought into being through pilot programs or by kind of key individuals, or sort of elements that are difficult to sustain as people move on to new jobs or funding stops. And actually, we need to have a more consistent approach to the sustainability of what we are doing. They've looked at many of the sort of case studies and highlights. Many of them we've seen before, from the full stock take to the case studies that are highlighted in the neighborhood guidance. And they also say we need to move to longer term consistency in funding as well. And also messaging from central government that neighborhoods are coming, and help the public understand what those are as well. So consistency across a number of areas. They talk about the accountability around it, and key performance indicators, and that they are really pushing for a steer towards outcomes rather than outputs. So not the number of people discussed at a multidisciplinary team meeting, but actually what's actually the impact on the community. So being really careful about the KPIs and the outcome measures that are selected. And they talk about a single shared mission as well. So bringing people including all the services, the wider public sector, the local authorities and social services and community voluntary sector behind a single shared mission. So that's going to require a lot of that relationship building, isn't it, as well? But really giving a neighborhood an identity behind that. And then they make some. We can pause there, Gandhi, if you like. I can move on to the recommendations, and then we discuss how do you want to handle it.
I think let's go through the whole thing and just noting time and stuff. But if people do have comments that they want to ask or questions they want us to ask us, please take that opportunity now.
I'll go high level on the recommendations. So they make some general recommendations. So they're calling for strengthened investment in the most deprived neighborhoods with a neighborhood health fund. They talk about devolution with health in mind. So I think what they mean is the local mayoral authorities and combined authorities. They say actually bear health in mind. And, in places like Manchester, there's combined responsibility for health and social care devolved to the local administration there under Andy Burnham. So they're kind of, making reference to that. Implement a new model of national planning and regulation. So this will take time. And actually they're saying give us a roadmap in terms of how to get there within the 10-year plan. Acknowledge that this will take time and may need some regulatory change. And they're calling on for clear communication of a coherent vision of neighborhood health. And I think that was the trouble that we were having at the conference in terms of we've been asked to start to move towards developing things, but the destination still feels a little bit woolly. So I think they're calling for better coordination of a coherent vision. And then in terms of some 3 specific recommendations for the NHS and ICBs in particular, say measure success in outcomes, not outputs, develop devolved place-based budgets. So there's a suggestion of ICBs devolving budgets to smaller elements within it, so potentially localities or places, and calling for investment in the development of capacity and resources for neighborhood working. So that's that resource word there. And in particular, they talk about investing in training and development for the NHS staff. They need to either redeploy NHS staff or make new investments, invest in community leaders as well, and target investments and support to the most disadvantaged communities. So I think some interesting scoping work. And actually, for those of us who are involved in the development of INTs, that's really, really useful when large organizations do, a detailed exercise on policy like this and produce this guidance. So I'd encourage people to go and have a read, really. Have you got any thoughts, Gandhi?
I think the key thing is still waiting to understand what does neighborhoods mean. But I think one of the things that I know that we talked about, particularly at the conference, was maybe we don't wait to be done upon and lead in this, and maybe PCNs in particular should be taking the lead in terms of actually determining what happens. And I think one of the challenges we're going to see is those areas where they haven't really engaged with the INT working prior to this are going to have a much longer journey to get to where they need to be, whereas those that potentially have started some of that work and even where the PCNs or the practices are leading that INT development, actually they're likely to do better, I think, in the longer term. That's my perspective of it.
Yeah, that's what I heard loud and clear from Duncan at the conference, really, was encouragement to actually fill that space and fill that uncertainty with plans that we know will benefit the populations and be a way of making good use of any funding or opportunities that come down the line. And a theme that came through from the conference, Tara said this should be the relationships conference, because that was something that came up again and again. And I guess if areas can start to, we sort of know who the services and the organizations that need to be involved in neighborhoods. So really beginning to invest in developing those relationships in anticipation of further guidance, or even, deciding what would look good in your area, I think will be a really good place to start and be investing in at the moment. And I do wonder if actually the guidance that we get actually devolves a lot of those decisions about the form, function and focus of neighborhoods to local communities as well, because, it has to be tailored to the needs of the neighborhood, doesn't it? So actually probably a lot of those decisions will be down to us, and we can begin to make them now in anticipation of further steer from the center.
Lots to think about. So I guess this is a chance for those of you that are watching us live to ask your questions. I guess just before we get to those, if we have them, I think it's probably worth we do a quick summary of what we've covered today, Andy. How about I take the first part and you take the second part? Does that sound all
Go
right?
for it.
All right. So in the summary of this episode for our May update for EGP learning, I guess there's key things to be mindful of. The big one that's come through is absolutely, we had an amazing conference at PCM Plus, which if you want to still get access to the information of that's still available for you to do so. The link for that is down below. However, in addition to that, one of the themes that came through from that conference was this need for people to want to talk about AI. And in AI, in particular in general practice and healthcare, there is loads of information coming through, including specifically some guidance of how to use AI scribe or ambient voice technology, as it's being called in that guidance, in general practice, and particularly an implementation roadmap for you to consider, where we talked about things like clinical safety officers, regulation, certificates you need to do, all these steps that you probably need to be doing before you start using them in practice, and how to use that safely as well. We also then cover some stories around how certain tools are being used across the country, for example, scanning or AI scanning for patients with potential lung cancer from the information that's found, as well as dermatology-based ones to try and pick up more melanomas at a potentially higher rate and things using AI-based tools. We then also talked about the Accurx conference, where I went and had a few quite interesting video contents produced, including a live stream from the conference itself, which particularly talked around their big announcement, which was their AI scribe, sort of Accurx scribe powered by Tandem is what it's called, in their partnership with the group called Tandem, which I believe is the largest AI integration in Europe, from what they mentioned at the conference. So quite significant, as well as various other features that are coming through from Accurx. But on the back of that, just recognizing that process and that information people may want to know about using AI in general practice. We then transitioned to talk about neighborhoods, which Andy's going to talk about.
Yeah, so our focus then shift to neighborhoods, which was another area that had a lot of discussion at the PCM Plus conference. Videos available, see link. In particular, Duncan Gooch spoke there about neighborhoods. He's the new NHS Confed lead for neighborhoods. Was asked this thorny question: what is a neighborhood? Really, really difficult to define. So, so today we looked at some new guidance that has come out from NHS Confederation. They published a report detailing the outputs from a policy sprint that was done by experts at NHS Confed. And I guess to summarize the key themes from that, they talked about moving from sort of top-down changes to a trust-based model, with trust being really, really important to build, moving to prevention. And they acknowledge that it's at a neighborhood level that most of the socioeconomic factors that contribute to people's medical conditions and good health, actually exist. So it's the right level to tackle things. They're encouraging tough decisions about resource allocation and advocating devolution of resources and decision making to places or levels below that of the ICB, so that we can have solutions tailored to neighborhoods. They're encouraging a focus on outcomes, not outputs, in terms of how we set the metrics and KPIs by which we judge the success of neighborhoods. So advocating for fewer, simpler performance metrics that are focused on outputs. They're encouraging more decentralization. So actually thinking about a neighborhood approach to devolution. We're getting mayoral authorities. There are other changes that are happening, how local government is organized, and they're suggesting that become part of conversations around health and health neighborhoods. And they highlight this is a once in a generation opportunity. So, and actually there's been quite a lot of hype about it, so that we really need to follow through on this. It's a really, really interesting article, and I'd encourage people to take a look.
And if you want to do so, then all those details are down below in the show notes for you to do that, including all the links to the articles and videos and stuff that we've covered in today's episode. We will be back in a couple of weeks to go through more data in terms of information that's going on in general practice. Next week, we've got some interesting footage coming out for you on the channel. In fact, there's like 9 videos coming out just in this past week and next week in total. So make sure you are subscribed. And as ever, we'll be here to take and answer primary care and learning. We will catch you in the next episode.